So, hello everyone. Thank you to Kath and the team AWTTC for asking me to speak here this morning. I want to talk about opioids and the opioid crisis that we face here in Wales and the UK more generally. I'm not going to be giving an ABC of how to taper. What I want us all to think about really is how we got here and how we can get out of it. So I'm going to start at the end by saying that the problem with overprescription of opioids and other analgesics is not simply a medication issue, it's a societal one. We will not resolve the crisis of prescribing unless we accept that radical change is needed in how we think about pain and how we support the people who are living with it. Estimates place the number of people living with pain in Wales as high as 1.3 million. So we need a properly thought-out, joined-up approach to tackling this across sectors, across professions, and across the country. So shall we start with the what? What's going on? We have all these headlines, radio programs, journal articles, lots of them using very emotive language, crisis, addiction, misuse, alarm bells. Pharma companies are being sued in America for mis-selling, failing to declare information about the medicines, such as their propensity for misuse, bribing prescribers, and we know the same tactics have been used here in the UK. Do we have a crisis of addiction here in Wales? We know that we have a high incidence of misuse. Swansea, for example, has the highest number of deaths from opioid overdose in England and Wales, according to the latest statistics. But do we know for sure that that is due to medicines being prescribed by doctors, nurses, and pharmacists? No, we don't. The likelihood is that the majority are due to illicit use. However, we do know that more people are seeking support from substance misuse services, and we also know that the age of those people is increasing. We also know that more people are being admitted to hospital or turning up at A&E with overdoses, and that isn't necessarily all due to misuse, though. So it points towards a growing problem, or perhaps more accurately, a growing acknowledgement of the problem. So for data lovers amongst us, this is from my research, which utilises data from 78% of GP practices in Wales and is accessed via the SAIL data bank based at Swansea University. So what we can see from this and the dispensing data that we pour over in medicines management departments all over the country is that we have seen a large increase in opioid prescribing across Wales since the early 2000s. And depending on your source, it's somewhere around 40 to 50% increase in that time. And that's with all opioids. What we've seen with strong opioids, which is what this first graph shows, is an increase of just over 300% in the 11 years from 2005 to 2015. So 4 times as many opioids, strong opioids, being prescribed in 2015. And if we look at the breakdown of all opioids, then what we can see here is that actually what we have in Wales is a massive amount of codeine prescription. In fact, over 60% of opioid prescriptions in Wales are for codeine. So we've now started to see a small decline in overall prescribing, accounted for the most part by the work done to reduce tramadol prescribing. But of course, all these nice graphs don't really tell us a huge amount. This isn't proof of rising misuse or opioid-associated deaths. It doesn't tell us anything about resource utilisation. But what we know from experience is the more prescriptions we issue, the greater the likelihood of some of them going to the wrong person, or to the right person but in the wrong way. And the more opioids we have in circulation, the worse it is likely to be for society as a whole. There is a tendency, perhaps more particularly in the mainstream media, to blame a UK opioid crisis on primary care, and more specifically on GPs. And this is absolutely not the case, in my opinion anyway. The use of opioids has increased in all sectors. So the drive to get people out of hospital following surgery as quickly as possible has been demonstrated here in the UK and elsewhere to be a cause of increased opioid use in the population as a whole. Discharge with inadequate follow-up or advice to primary care on post-operative management, failing to inform people how to reduce their medicines as their condition improves and they get fitter and healthier, all contribute to that. And similarly, long waiting times for surgery or other medical interventions are often plastered over by increasing analgesia, at the behest very often of specialists who don't take the responsibility of the prescription itself, but who may well have told the patient to go and get this from your GP, setting up an expectation that can be difficult to overcome. So yes, prescribing is then recorded in primary care, and yes, GPs are the main prescribers in that sector. However, saying that prescribing is entirely the GP's decision massively underplays the complexity that we actually face in practice. So perhaps our concern should be angled towards the people most commonly affected by pain and opioids. What this graph shows is that double the number of opioid prescriptions are issued in the most deprived areas of Wales, as we see in the least deprived. And these are areas where people are less likely to be working, less likely to have high levels of health literacy, have trouble accessing services, or have trouble engaging with alternative ways of managing pain. So my point here, in case you weren't sure what it might be, is that opioid prescribing should be all of our concern, because whoever we are, wherever we work, it's going to affect us in some way. And furthermore, there are just too many people using these medicines and living with pain for us to make it somebody else's problem to solve. I provided this quote to the Advisory Panel on Substance Misuse in 2015. And at that time, I said that as part of my evidence, that whilst it was laudable to look into the issue of dependence on prescribed medicines, there needs to be an acceptance that the solution will only come from change to the whole system, to increasing public awareness of pain as a long-term condition, to educate people, professionals and otherwise, that pain is actually a normal part of life, impacted by multiple factors that act to increase or decrease our perception of it, and the intensity and the fear associated with the experience. So I think, yes, we absolutely have a dependency issue in Wales, but have we considered that practitioners are as dependent on opioids as the people we prescribe them for? Let's have a think about who for a minute. This is Gary. I have his permission to use these videos. Gary is 58, and about 14 years ago, he had an accident at work that left him in hospital for a number of weeks. He actually recovered, went back to work, got on with his life, which included supporting his daughter who has cerebral palsy and requires high-level care. However, a couple of years after that, he began experiencing back pain that he couldn't shift. He saw a spinal surgeon who told him that there was significant damage to his spine, but there was no value in operating. He was sent to a pain clinic who gave him injections and told his GP to prescribe medicines. Nowadays, Gary uses a wheelchair to go out. He stopped work 10 years ago because he couldn't continue in his existing job. And retraining wasn't an option for him because he has severe dyslexia. So he was signed off as disabled and placed on benefits. His wife, Sue, whose voice features in one of these videos, she became his carer. He stopped going out, stopped socialising, and he wanted to take up painting, but that never really came to anything. He came to see me in his GP practice about 4 years ago. He was a bit reluctant. He hadn't been impressed with previous interactions with pain specialists who had told him that there was nothing they could do for him, particularly as he didn't want any more spinal injections because they didn't work.
I was first invited to come and see you. I wasn't going to do it because of the time that, like I say, I went to different pain specialists, and you'd always get more medication than you didn't go for it, but you always got extra medication.
Have to excuse, this is all filmed on an iPhone, so by me, so apologies for the amateur nature of it. Anyway, when Gary first came to see me, he was taking tramadol, buprenorphine, pregabalin, and amitriptyline, and some morphine, actually. He couldn't tell me if any of it worked. He didn't really know what I meant by does it work. But it was quite clear that he wasn't functioning. As I said, a few years prior to him meeting me, he'd bought some watercolour paints. He'd done one painting and then put it all away because he couldn't sit at the table long enough to complete what he wanted. So the question I asked him and repeated at every meeting was, what matters to you? Initially, I didn't get much of a response to any question. These films are from May, which is 2 years since the major reduction in his opioid dose.
The bad part about everything is the 3 years where I was on so much medication that I missed with Sue and the kids because I was just so doped up with medication that all I did was sleep. That was it, just sleep. Sometimes I never got dressed. Sometimes even go in the shower because of all the, I don't know, fears. I used to have nightmares, regular. Well, some funny things as well, mind. I mean, I had a motorbike in the bedroom one night.
What does this tell us? It tells us that opioids don't improve lives for many, many people, but it can be really hard to notice. Gary didn't just fall asleep one day. It was a gradual process as the doses increased and his mood lowered and he became increasingly debilitated. He continued to report pain and medication was added and increased. He became more debilitated. His chances of rehabilitation and returning to work faded as time went on. So why? Why do we do this? If we want to change opioid prescribing trends, avert a crisis, or ideally if we want to ensure that people are better supported when they have pain to live effective and meaningful lives, then we need to understand why what we've done for years hasn't worked. So Kathy Stannard, who is the leading exponent on opioid use in persisting pain, she's chair of the NICE guidelines on chronic pain management, she wrote this in a recent article. Societal expectation is key to this. As clinicians, healthcare managers, policymakers, we are part of that society, and it is our expectations that are as much an issue as the people we are seeing in practice. So we want there to be a fix for this problem, and we want it to be straightforward, cost-effective, ideally free, and we want it tomorrow. So the problem of opioid prescribing is not just issuing too many prescriptions. Opioids and other analgesics cause a multitude of long-term harms. So Gary now has medication-induced pituitary dysfunction. He doesn't produce his own cortisol and so is on hydrocortisone replacement therapy. And that's partly due to high-dose inhaled corticosteroids and partly due to long-term high-dose opioids. And in his case, it doesn't appear reversible. So as well as providing treatment that doesn't work in terms of improving function and quality of life, we are continuing medicines that cause new harms to people. And this isn't misuse. Gary rarely took his medicines differently to how they were prescribed. He has never made a request for an early prescription, has never lost a prescription and needed a replacement.
What do you think would have helped you way back when? things that you know now that you wish you knew back
Well,
then?
I wish I'd have known, like I said, about you can alter other hormones and you can actually finish up worse than what you was. The fact that...
Do you think that would have stopped you taking it, or would you have felt less... more reluctant to increase doses?
I would have probably still taken it because the amount of pain I was in.
Crucially, even having come out the other side, Gary still thinks that if in the same situation, even perhaps knowing the problems that the medicines have caused him, he would still take them because of the pain he was experiencing at the time. However, is this what we think we would do because we don't realise there are other options, other more sustainable and less harmful options available? In Gary's case, all of this has been discussed, but I wonder if despite that and despite what happened to him after reducing his analgesics, that we still have to get over this thought of, well, that doesn't apply to me. People might be given information about potential harms of medicines and think, well, that's going to happen to somebody else. That's not going to happen to me. So another why do we prescribe opioids? We know all of this. We've known a lot of this information for a long time now, and yet we are still prescribing them. We're still seeing a sort of increase, a slower increase perhaps, but we're still seeing increases in strong opioid prescribing across Wales. Hillel Finniston put this forward, this opinion, a couple of years ago, and it gave voice to what many people working in pain management were already thinking. But what do we mean by pain management resources? Does this mean more traditional secondary care pain services? No, I don't think it does. I hope it doesn't. If nothing else, we need to think more intelligently about what we already have available and how we use it. So how are we going to change things? First, we need to acknowledge there are two issues. We have all of the people currently prescribed opioids, a lot of whom are going to find some of this information that we're providing about the harm of their painkillers, the futility of using analgesics, in the longer term, the need to take different approaches to living with pain. They're going to find that really difficult to stomach because reversing what you've been saying for 20 years is really confusing to people. But then there's the future. There's the person walking in to see their GP tomorrow, and for whom we cannot simply do the same old thing and hope to get a different result. So this document was launched by Welsh Government in April. I don't know if anyone's seen it. The purpose was to provide evidence-based guidance for health boards and other service providers and people living with pain in terms of effective ways of living with pain. The document focuses, though, perhaps unfortunately, on pain services, and discusses the benefits of self-management, but there's limited pressure on health boards to examine what's actually being provided right now in their areas and whether it is having a beneficial effect on the populations that they serve. I'd suggest that what we need is a national strategy for pain, one that encompasses more than healthcare. We need to move away from pain being a medical problem. By definition, the majority of people with persistent pain, it occurs after the time of healing. So that implies that there's not an ongoing damage that needs physically mending. We need a public awareness campaign that informs people that pain is part of life, that ongoing pain is not necessarily a sign of ongoing harm, and that pain-free is unlikely to be achieved, but that a happy and active life is definitely possible. We need employers, including the NHS, to show understanding and support to people who are struggling. We need more activity programs and social prescribing. We'll hear about that today. We need more, and we need people to take responsibility for their own healthcare choices. And of course, this isn't going to happen quickly. Plans are in place to move towards it, but we've seen with antimicrobials, for example, how much time and effort and persistent messaging is required to make change occur. And that's in an area where fundamentally professionals have the option of saying no, in the knowledge that if an antibiotic isn't indicated, the patient is unlikely to come to harm as a result. So I don't think we're in that place with pain currently, because whilst we can say no, pain won't necessarily resolve on its own a few days later. The impact of pain on employment, relationships, disability, healthcare, social care, and so on, results in this sort of ripple effect that reaches well beyond the GP surgery. And we can all play our part in this. So if the only thing you do after today is go away, understanding that we'll only make a difference to opioid prescribing if we demand something different from our health boards, social care, ourselves, and the people that we support. So Gary's come a long way, but he's been left with long-term problems that he will need to manage. But wouldn't it have been better if this hadn't happened in the first place? Wouldn't it have been better if he hadn't missed that 3 years with his family, if he'd been encouraged to regain his activity, to concentrate his time and effort on what mattered to him? An opioid trial to establish if the medicines actually helped to improve function might have prevented him ending up on these medicines for 10 years. A yearly face-to-face review looking at his functioning, use of medicines, long-term health issues, might have picked up the pituitary problems earlier and given a better chance of reversal.
And it also, which I didn't know about, and I think people should know about, that taking all this medication over long periods of time can alter your body. It can alter your hormone levels, your cortisol levels, and they affect other things, and I don't think people realise that some pain medication, that it can start over a long period of time, it can start causing more problems.
So we need to change what we do tomorrow if someone presents to us with pain. For those already established on these medicines, we need to support them to understand the problems and the potential harms being caused. Opioids have a significant effect on quality of life. The goal of pain management is enablement, function, doing more in spite of pain. But what is more? It's more of what matters to the individual.
It was when we did start lowering the medication, it was like waking up. And it was going from doing absolutely nothing to being able to go back painting. And it is a worry, the pain, but I think my head's more clearer, and I think you can, because you are awake, I believe you can manage it more yourself, if you know what I mean. You're in a better headspace.
There are guidelines around tapering, but they're often not designed for primary care, which, let's face it, is where most of this is going to happen. Ideally, people should have multidisciplinary support through this process. Realistically, though, certainly at the moment, that's not going to happen, in part because even if we had fully integrated pain services all over Wales, the numbers involved only would skim the surface. They see so few people compared to how many people are out there. Ideally, people should have support to find and engage with other means of living with pain effectively, but realistically that can be difficult, and many simply don't want to because they remain in the mindset that pain is something that a doctor or another healthcare professional should be able to do something about. Opioid tapering takes time. As clinicians, we must be flexible in our approach. We need to be given time to talk to people and ask them what matters to you. And then we need to be able to guide them towards that. And this needs to be done before we prescribe and not when we're trying to rein in what's already happened.
It was the old,
It was the fact that you could say, I'm not ready to do the next step, or
Yeah.
give it a few weeks and then we'll try again, or it was the fact that you could say, rather than a doctor saying to you, right, we're doing this, that and the other.
Yes, it was, yes.
So it was working together
Yes.
and tailoring it to you as opposed to just following a sheet.
Yes.
I think.
Definitely. Definitely. Because everybody's different.
I don't know if you could hear that Sue in the background talking about how we changed things as we went along, depending how Gary felt about whether he was ready for a change or not. So we need to move away from trying to rescue people towards coaching them to make better choices for themselves and their families. In March this year, Gary put on an exhibition of his paintings in support of the Swansea Veterans Association, and he raised over £2,000 in sales. Currently, he's finishing an installation art project in Swansea, and he's the only non-professional artist involved in that. By his own very understated admission, his quality of life has improved immeasurably in the last 4 years following the reductions in his medicines. He's woken up. To make a difference to the problem of overprescribing of opioids, we must take a different approach, and it must involve more than prescribing targets and audits. Medicines management departments and GP practices are not going to resolve this problem on their own. So we must demand more, and we need to question what the health boards are doing on a wider scale to support this work. The problem with the overprescription of opioids and other analgesics is not simply a medication issue. It is societal. And we will not resolve the crisis of prescribing unless we accept that radical change is needed in how we think about pain and how we support people to live with it.
It was when we did start lowering the medication, it was like waking up.
Thank you.